The following podcast is part of a certified educational activity titled Calibrating Clinical Approaches for Metastatic Colorectal and Lung Cancers, Insights on Molecular Testing and BRAF Inhibitors in the Community Setting. Access the entire activity and complete the post-test at peerview.com/NYM860. Downloadable slides and practice aids are also available.
Hello, and welcome to Calibrating the Clinical Approach for Metastatic Colorectal and Lung Cancers. My name is Dr. Van Morris, and I am a gastrointestinal medical oncologist at the University of Texas MD Anderson Cancer Center in Houston, Texas. And I'm really excited today to be joined with me by Dr. EBI Dagogo-Jack, a thoracic medical oncologist at Massachusetts General Hospital. Welcome, Dr. Dagogo-Jack. I'm really excited about today.
Thank you. It's great to be here, and I'm really looking forward to this excellent discussion that spans multiple diseases and a particularly, I think, compelling target, and thinking about how we can move targeted therapies and implement them in the community-based setting.
So kind of threefold. Our goals are really to improve the understanding of our audience for the rationale for biomarker testing in clinical oncology. Kind of we go over some of the latest and most exciting clinical trial data, as well as evolving guideline recommendations for the treatment of BRAF V600E, metastatic colorectal, and non-small cell lung cancers. We'll also seek to really enhance your skills to develop treatment plans that incorporate BRAF inhibitors in the management of metastatic colorectal and non-small cell lung cancers. Again, based on the latest evidence, the molecular testing results that may become available to you, and really other patient-centered considerations as well. We also hope to equip you with the tools that address the various nuances of treatment planning and coordination of care for these patients, which includes management of adverse events and toxicities, dose adjustments, educating and empowering patients about their care, and really doing so to ensure that there's shared decision-making going on between you and your patients for these BRAF mutated cancers. So in our first module, we'll be addressing the outstanding concerns in BRAF mutated lung and colorectal cancers. So I'll say that as we'll talk about later, the treatment landscape for BRAF mutated colorectal cancer is rapidly evolving, with a lot of data suggesting that we should be testing early in the treatment course of a patient with stage 4 colorectal cancer. But as you can see here, there still are a lot of shortcomings when it comes to the treatment management of patients with colorectal cancer. We have done better over time in testing patients in the frontline setting, but you can see in the middle figure here, when it comes to BRAF mutated colorectal cancer, some series are saying that, in the frontline setting, as many as half of patients may not be, or an oncologist may not be aware of their the BRAF V600E status. Dr. Dagogo-Jack, how are you all doing with regards to non-small cell lung cancer in this space?
So thinking about biomarker testing in non-small cell lung cancer, I think though it has been a cornerstone of our management of at least advanced non-small cell lung cancer, also moving into the early stage setting, I think that there's still room for improvement. And so this is a somewhat dated study now, but I think more recent updated studies reflect similar trends. So why is it that we're missing biomarker testing for our patients? And I think that it seems like a simple concept, but actually can be quite challenging to implement. And there's multiple points of drop off. I like this slide here because it illustrates, especially if we focus on the latter half of the slides, all the pain points or pressure points that can lead to failure to achieve full biomarker testing. So this is really just showing all the gaps in the delivery of precision oncology, particularly in the context of metastatic or advanced non-small cell lung cancer. And so I'll turn it back over to you to think about current guideline testing, molecular testing, colorectal cancer.
Yeah, thank you. And I think it just, we really, in educating our trainees at MD Anderson, who are, young oncologists, when we're teaching them the management of colorectal cancer, we just, really make the point and emphasize early when a patient is diagnosed with colorectal cancer, really one of the first comes with stage 4 disease, one of the first questions you really need to be asking is, what is the molecular profiling pattern for this patient, because of the personalization of therapies, which of targeted therapies, which can be available for our patient population. Still kind of lag behind you guys in non-small cell lung cancer, but we're trying to catch up with you guys. These tend to be the major mutations that we look at and look for and consider when we're treating patients with metastatic colorectal cancer. As you mentioned, kind of with non-small cell lung cancer, next generation sequencing is something that I think that we're doing more and more of. When it comes to looking for microsatellite instability or deficient mismatch repair, there are a couple of ways to do this. Certainly, I think immunohistochemistry is the most common, but keep in mind that it can miss around 5% of patients who have MSI high tumors. So this is where the PCR testing or really NGS testing can help to improve the sensitivity for detecting these MSI high deficient mismatch repair tumors, and help identify patients who could benefit from immunotherapy.
Yeah, so just briefly, in the context of non-small cell lung cancer, so we can kind of dive into the meat of today's presentation, but just to frame the context. So non-small cell lung cancer, there are a variety of molecular alterations. We know that this is a heterogeneous disease, and listed in this table is the ever-expanding number of fusions and mutations that are relevant. And we can see for each of them, there's a variety of targeted therapies that are approved, and these can really improve prognosis for our patients. So important to identify these molecular alterations. Today, we're going to focus our attention on BRAF V600E mutations. And these are just based on the therapeutic relevance of finding these molecular alterations, and also the prognostic implications of finding these molecular alterations. If you look at the NCCN and other kind of widely regarded guidelines, it is really imperative that someone practicing in the thoracic oncology space perform biomarker testing, and importantly, comprehensive biomarker testing using assays that can detect a variety of molecular alterations, as well as doing immunohistochemistry for PD-L1 status to determine whether or not a patient should start with immunotherapy plus or minus chemotherapy or targeted therapy. So molecular testing, I think, is really the cornerstone of that we need and require for us to be able to make these critical decisions with respect to BRAF targeted therapies. And one thing to point out, I had mentioned in that graphic where we're looking at the points of drop off, the things that lead to lack of realization of comprehensive molecular testing. And it was really heavily predicated on the inadequacies of tissue. Fortunately, we can lean on liquid biopsies, so plasma or ctDNA profiling, to give us some of this very important information. It's not a perfect test, but if you find something on a liquid biopsy, lots of studies across solid tumors have demonstrated that it is high yield and something you can act on. And just really briefly, just to point out that it is important to involve our patients in these discussions around molecular testing. This is just a survey that really asks patients what they want to know when they're having discussions about molecular testing. And one key point is that the vast majority of patients wanted this information from their treating team, so the nurse or the physician taking care of them. And so with that, I'll turn it back over to you, Dr. Morrison, to kick us off in thinking about BRAF in the context of colorectal cancer.
Yeah, thank you, Dr. Dagogo-Jack. So let's kind of start off. When we think about the what BRAF V600 mutations do, as you can see here, when in the figure on the right, relative to kind of normal cell growth, when you have these BRAF V600E mutations, they activate and kind of hyperactivate this MAP kinase pathway that you can see here, and when turned on, really stimulate these cancer cells to grow, divide, proliferate, and behave like cancers. We very much know that for the 8 to 10% of patients with colorectal cancer whose tumors harbor these BRAF V600E mutations, it's a unique clinical and biologic population. BRAF V600E mutations are, among the most, aggressive and associate with the worst prognosis overall among patients with a diagnosis of stage 4 colorectal cancer. There are certain, clinical and pathologic factors that associate with these mutations that if you're seeing these patients for the first time in clinic and they come with these factors, in their radiology reports or their pathology reports, a right-sided colon tumor, a more locally advanced T4 primary tumor, poorly differentiated tumors, a higher suspicion that you may have a BRAF V600E mutation. They're also associated with higher tumor mutation burden, higher methylation patterns, which again may get to some of the differing biology that we see drive these tumors. And then as well, kind of different changes in the transcriptome, specifically, characterized by higher immune activation and an epithelial to mesenchymal transition phenotype as well. So again, oftentimes these patients, as we talked about, have kind of more poorly differentiated tumors. We oftentimes see these associated with advanced age, so people over the age of 70, and more commonly, for reasons that are still unclear, more commonly occur in women than male patients. So, we know that these mutations occur in up to 10% of all patients with colorectal cancer. And, as we learned early, almost 15 years ago in melanoma and, then in non-small cell lung cancer, there are BRAF inhibitors which are effective at blocking BRAF V600E solid tumors. We know that if we add a MEK inhibitor, that can kind of deepen the response rates that you see as a combination targeted therapy. You can see nice response rates with either the monotherapy or the combination BRAF MEK therapies, in the double digit setting. And this is what, several years ago led to the kind of pan-tumor FDA approval for BRAF MEK combination therapies in patients with BRAF V600E solid tumors. The important point to make was that FDA recommendation was made with one exception, and the FDA said this does not apply to BRAF V600E metastatic colorectal cancer. And there's a reason for that. When they looked at the same drugs and the same treatment approaches with the same BRAF V600E mutation in the context of colorectal cancer, you can see that the response rates are in the single digits to the with the BRAF inhibitors as monotherapy, and then 12% with the BRAF MEK. So the numbers are much lower in BRAF V600E metastatic colorectal cancer than in other BRAF V600E metastatic solid tumors. And I think this is such a cool and interesting story of bench to bedside medicine. So we were seeing in the clinic that these drugs, which we know to work in other solid tumors, were not working in patients with colorectal cancer. So different teams went back to the lab and said, if we block BRAF V600E with a BRAF inhibitor in colorectal cancer models, what happens? And what we saw was that there was a unique upregulation of EGFR upon BRAF V600 blockade that you don't necessarily see in other tumors. So this kind of gave us a signal into why we were seeing these poor response rates. But the question is, what are we going to do about that? And as we all know, the nice thing that we have the availability of EGFR inhibitors. So this led to study of BRAF inhibitors in combination with anti-EGFR therapies in patients with BRAF V600E metastatic colorectal cancer, and ultimately culminated in the first FDA approval for the BRAF inhibitor encorafenib in combination with cetuximab. And this was the phase 3 Beacon trial that looked at patients with treatment refractory BRAF V600E metastatic colorectal cancer. So again, this was second line and beyond, and randomized patients to either kind of a control arm of irinotecan and cetuximab, or a BRAF EGFR combination encorafenib cetuximab alone, or with the addition of the MEK inhibitor binimetinib. And as you can see here, with the primary endpoints being overall response relative to irinotecan cetux, there was this was a positive phase 3 study with improved overall response rates of 20% with encostitux, 26% with encostitux and binimetinib. But when you looked at the overall survival, in the left here, in the top left, you can see the overall survival with encorafenib, binimetinib, and cetuximab of 9.3 months. With encorafenib and cetuximab, no MEK inhibitor, the overall survival was 9.3 months, exactly the same. So the FDA looked at this data and said, the FDA looked at this data and said, Because the overall survival is not different between the two experimental groups, we're going to approve encorafenib cetuximab for treatment refractory BRAF V600E metastatic colorectal cancer. It's important, I think, to mention that even though this was a win and a success moving forward, you can see in the bottom right that the progression-free survival for encorafenib cetuximab is only 4.3 months. So it is a win, but I think it's a step forward and really highlights need for continued work in this space. So we had the FDA approval for encorafenib and cetuximab. So then the question became, what happens if we move this to the frontline setting? And this was, data that's been reported in 2025 now. This was the Breakwater study where they said, let's look at BRAF EGFR combinations in the frontline setting. So patients with previously untreated BRAF V600E metastatic colorectal cancer were randomized 1:1:1 with standard of care chemotherapy at the discretion of the treating investigator, encorafenib cetuximab alone, or encorafenib cetuximab with FOLFOX chemotherapy. And as you can see here in the blue, which represents the chemo plus encorafenib cetuximab arm, this was also a positive study with an overall response rate of almost 66% with FOLFOX plus encorafenib cetuximab. With encorafenib cetuximab alone, you can see a lower response rate of around 46%. And both of these were better than chemotherapy alone. So this was a positive study. And I think it's important to see that in the figure on the right here in the middle, you can see that it didn't take long. If the patients were going to respond, you knew pretty much at the first restaging that the patients were going to have, a benefit to treatment with the chemotherapy and encorafenib cetuximab combination. This was the PFS data as well that kind of confirmed what we had seen with, and you might expect with the overall response patterns as well. The combination of FOLFOX with encorafenib cetuximab was associated with, a prolonged median progression-free survival, 12.8 months with the chemo-targeted therapy combination relative to 7.1 months for the chemotherapy control arm and 6.8 months with encorafenib cetuximab alone. So, and I'll say, I think that this was really the data that was presented at ASCO this past year and then subsequently published in the New England Journal of Medicine that really just caused, a collective jaw drop when presented. And what you can see here is that literally the addition of encorafenib cetuximab to chemotherapy relative to chemotherapy alone doubles the overall survival from 15.1 months to 30.3 months. And, as a trainee 15 years ago now, writing these papers when there was just chemotherapy, I was used to writing papers that said overall survival for patients with BRAF V600E metastatic colorectal cancer is less than 12 months. And now we're at a point where median overall survival is over 2.5 years now. So a lot of exciting, data being generated out of this combination. And as you can see in the forest plot on the right here, really no matter the clinical factors, all patients seem to benefit from the addition of encorafenib cetuximab to chemotherapy. So very exciting, very convincing data for getting this to our patients in the frontline setting. Overall, as you can see, and this was data that was updated at ESMO this year, the side effect profile of combining the targeted therapies with the chemotherapy is as to be expected. There's not a lot of grade 3 and 4 toxicity associated with the chemo targeted therapy combination. Really, the most common was a decreased neutrophil count. I think it's important to mention that this trial did mandate use of the 5-FU bolus with leucovorin, and this is something that we omit in clinical practice of our patients with metastatic colorectal cancer. So I do think that we will see in the real world that the adverse event, the treatment emergent adverse event profile may be, all the more favorable, hopefully. and getting this to our patients. So what about the role of immunotherapy in the management of BRAF V600E colorectal cancer? We did a study at MD Anderson where we looked at encorafenib cetuximab with a combination of nivolumab in patients who had treatment refractory BRAF V600E metastatic colorectal cancer. You can remember from the Beacon study I showed earlier that the median progression-free survival with encorafenib cetuximab alone was 4.3 months. We saw a median PFS of 7.4 months and an overall response rate in our study of 50%. With the addition of nivolumab to encorafenib cetuximab. And again, you may recall from Beacon in the phase 3 study that was 20%. So some really exciting, response from our single institution study at MD Anderson. We did some profiling that we published in this, that was accompanied this publication in terms of some RNA signatures, and found that, again, immune activation signatures when patients had them in their tumors really correlated and associated with a benefit to the encorafenib cetuximab nivolumab combination. And again, I think this will highlight future directions in further personalizing therapies moving forward for patients with this disease. But I will say it wasn't just our study that suggested there may be some interplay between a MAP kinase immune checkpoint blockade treatment approach. This was data that came out of Dr. Ryan Corcoran and his team at Massachusetts General Hospital as a colleague of Dr. Dagogo-Jack, where they looked at a BRAF-MEK PD-1 combination and saw very similar rates as to what we had reported in our study at MD Anderson. So a lot of exciting work. We're looking to validate this in a SWOG study, which as you can see here, a randomized phase 2 trial looking at encorafenib cetuximab alone or in combination with nivolumab in this patient population. We expect this result to report out at ASCO next year. So one of the questions we get, is, well, what about patients with MSI high BRAF V600E colorectal cancer? Should I use targeted therapies? And I would always, approach this in the clinic by saying I still think that we should use immunotherapy up front and really let the MSI high deficient mismatch repair biomarker drive decision making. We know that there's positive data for PD-1 monotherapy alone from Keynote 177 and dual PD-1 CTLA-4 with nivolumab ipilimumab from the Checkmate 8HW studies relative to chemotherapy in the frontline setting for patients with MSI high metastatic colorectal cancer. And both of these studies showed that even among patients with who had the poor prognostic BRAF V600E mutation in their, MSI high deficient mismatch repair colorectal cancers, that immunotherapy was still beneficial even if they had a BRAF V600E mutation. There is a trial that's looking to build upon the Keynote trial that I referenced earlier, specifically to look at this question further. The CMARC trial, again, this trial is completed accrual. We're just waiting for the readout. But again, looking specifically at patients with a microsatellite instability high deficient mismatch repair colorectal cancer with a BRAF V600E mutation and randomizing patients to pembrolizumab alone or pembrolizumab in combination with encorafenib and cetuximab. So I look forward to kind of getting these answers, with these trial readouts moving forward. So, this really kind of it all goes back to our patients. I'm reminded as every time, I think and teach our fellows about BRAF mutated colorectal cancer, about a patient I met early in my career, a young patient who came with a diagnosis to her local ER with just abdominal pain. Her local oncologist thought this was, gallbladder disease, treated her empirically for acute cholecystitis with a cholecystectomy. And lo and behold, when they went in for the surgery, found instead a large hepatic flexure mass with diffuse peritoneal disease. You can see this patient's CT on the right, that was confirmed to be a microsatellite stable BRAF V600E metastatic colorectal cancer. So I think that we've learned a lot in the past 10 years since I've been a faculty member at MD Anderson in terms of treatment advances. But I think really the take-home point for me is that we need to know as soon as possible when a patient is diagnosed with metastatic colorectal cancer, does this patient or do they not have a BRAF V600E mutation? Because if so, we really want to be thinking about the breakwater data. But as we've shown before, we still don't do a really good job of identifying these patients. So I'm going to turn it over to you and ask you, Dr. Dagogo-Jack, how are you guys doing this in non-small cell lung cancer? Like, how do you operationalize this in clinical management to identify these mutations quickly?
Yeah, I think the key is quickly, right? I think there's a lot of consternation, and all of us had to remind ourselves in the non-small cell lung cancer landscape to sit on our hands a little bit, right? Because there's a tension when you have a very sick patient, but you know that you don't want to. You have kind of a short therapeutic window or a window for a therapeutic opportunity, I guess, and you want to make the right decision. And so I think a variety of strategies have been implemented, right? So if you have access to an in-house next generation sequencing panel, that certainly speeds time and speeds things up. But if you're based in a community-based setting, you often don't have access to that. So it's send-out testing, which can take 2, 3, 4 weeks, etc. So what I've seen is that people pair, as much as we would like comprehensive next-generation sequencing, single gene assays for the most kind of the things that most inform first-line treatment first, like a PCR or something like that. So perhaps in colorectal cancer, doing the BRAF PCR, there are opportunities to do that. In lung cancer, we might do EGFR and ALK in that setting. Or actually, I think one of the emerging technologies that has been most helpful and fruitful in this setting is actually liquid biopsy. So sending that ctDNA assay, turnaround time has really decreased over time. You can often get those tests within a week now, and quite comprehensive and quite informative. And I think what the holy grail and what people are always kind of reaching towards is reflex testing, right? And some institutions are fortunate enough to have very, very close partnerships with pathology that once they read out that this is a colorectal cancer, this is a lung cancer, they automatically do that testing. So you have that information before you meet the patient.
Yeah, we do that with MSI testing, I think, but you're right. Like, I think that's a huge area for improvement in terms of reflex testing and better collaboration with pathologists. I will very much echo your sentiments as well. Kind of give it the advances in the KRAS mutated targeted therapies now with BRAF V600E, as we've outlined here. We also are huge proponents of the liquid biopsy testing for just a quick turnaround. We can get that result back within 7 days, really before the port goes in and insurance is approved. We know, like, does this patient or do they not have a BRAF V600E mutation? Because the sooner we get them on targeted therapies, the better. I'll kind of just close out with just a couple of clinical scenarios that we get asked, by outside oncologists, which is, I didn't test in the frontline setting. I waited, and got that result back, and I just held on the BRAF V600E, targeted therapies until the second line setting. Can I just go ahead and use the breakwater data in the second line setting and beyond? And I think we always think for right now, the answer is probably no. We know that chemotherapy is ineffective in the second line setting. So if this were the case, I would probably use the Beacon regimen alone of encorafenib cetuximab without chemotherapy. And another question we get is, I've seen the data with regards to Encostatox-Nivo. If my patient has progressed on the breakwater regimen with FOLFOX and encorafenib cetuximab, can I do encorafenib cetuximab, nivolumab, as a second line setting if they've already had the BRAF inhibitor? And I think the answer is no as well. We looked at this at MD Anderson, saw a response rate of 0% if they had already had the BRAF, been exposed to a BRAF targeted therapy. So we would not recommend that as well. So for the sake of time, I'll just kind of move quickly. Again, I think we have compelling data for use for combining encorafenib and cetuximab with FOLFOX in the frontline setting for patients with BRAF V600E metastatic colorectal cancer. We do anticipate data with FOLFIRI coming out in 2026, so this may be updated as well. But for right now, I think it's FOLFOX. For patients with treatment refractory disease, as long as they've not had the breakwater regimen in the frontline setting, I think that the encorafenib cetuximab, is what we, is the best standard of care. And we'll have to see how some of the data reads out in the randomized trials looking at the addition of immunotherapy. And then again, for frontline therapy, I still think even if patients have a deficient mismatch repair status with the BRAF V600E mutation, we should be prioritizing immunotherapy. And other trials are coming out, as I mentioned, which are exciting as well. So with that said, I'll hand this back over to you, Dr. Dagogo-Jack.
And so now we'll move on to talking about non-small cell lung cancer and really extending the precision care to BRAF mutated non-small cell lung cancer. We've learned a lot in the non-small cell lung cancer space from our colleagues in melanoma. And so I think important in the same way that Dr. Morris did to frame how we think about BRAF alterations, but specifically in non-small cell lung cancer. And here I'm intentionally using the word alterations because BRAF alterations, including fusions and point mutations, can be seen in about 4 to 5% of non-small cell lung cancer. That seems like a small number, but non-small cell lung cancer is quite a prevalent disease, so it does amount to a large number of patients. And so it is important to know the functional consequence of these BRAF alterations. And I think that really feeds into why certain therapies work and why we're focusing our attention on V600E mutations here instead of the variety of BRAF mutations and fusions that I pointed out. And so when we think about it, kind of in a simplest sense, preclinical studies have allowed us to subcategorize these BRAF alterations into 3 functional classes. So class 1, the hallmark or kind of the poster child of these alterations is really the V600 mutation. It allows BRAF to signal in a RAS-independent fashion and also as a monomer, so a single molecule. So those drugs that we will talk about next, and Dr. Morris has talked about, so the brafenib, vemurafenib, encorafenib, they are optimized to bind to BRAF monomers. So if you signal via a dimer, like some of those other BRAF mutations that are not V600E, or you require upstream receptor tyrosine kinases such as EGFR or RAS, etc., the monomer inhibitors, we're just trying something like the brafenib, is not as effective as a strategy. And so for that reason, we're actually really focusing our attention on BRAF V600E mutations. And so this is a study that we conducted in our group in collaboration with the team at Dana-Farber, but it's also been replicated by large-scale studies using Foundation Medicine data sets and other data sets to really just illustrate the heterogeneity of BRAF alterations encompassed in non-small cell lung cancer. V600 is the key one you're looking for class 1 when you're thinking about the therapies that we'll talk about. But there's also a variety of other BRAF alterations that you can see if you look at your next generation sequencing report. And these collectively, the non-V600 mutations, make up the bulk of BRAF mutations, but we really need to focus our attention on the class 1 or V600 mutations. And the reason that we focus our attention on class 1 or V600 mutations is that we have approved targeted therapies for this molecular subset of non-small cell lung cancer. So in 2017, we got the first approved targeted therapy, and that was the brafenib and trametinib. And about 2 years ago, so October 2023, we received an approval of encorafenib plus binimetinib based on the PHAROS study. And so this is a little bit of a departure from our therapeutic paradigm or how we think about targeted therapy in the context of non-small cell lung cancer, in the sense that we have historically used single oral therapies. So ALK targeted therapies, EGFR targeted therapies are single drugs, whereas here we're employing vertical blockade intentionally for reasons that Dr. Morse already mentioned, and we've learned from melanoma. So now let's look at the data that led to the approvals of these BRAF-MEK combinations in non-small cell lung cancer. So before we got to those BRAF-MEK combinations, the initial studies, these are phase 2 studies, actually explored monomer inhibitors as monotherapy, as a single agent. These are drugs like the brafenib and vemurafenib that were explored in phase 2 studies for BRAF V600E mutant non-small cell lung cancer. These studies showed response rates around 30 to 40% and median progression-free survival of around 5 to 6 months. And so this showed proof of principle, but it actually fell short of what we've come to expect as a benchmark of a viable targeted therapy for non-small cell lung cancer. So if we think about ALK, EGFR, and other targeted therapies, we're measuring progression-free survival in the order of years. And so that really was the impetus for thinking about, and also experience from melanoma and other diseases. This really formed the basis or the impetus for thinking about combinations. And so these are the data that supported the brafenib and trametinib combinations approval. This is based on data by Blanchard and colleagues in a non-comparative phase 2 study that looked at the dabrafenib monotherapy, but also dabrafenib and trametinib, first in patients who had not previously received treatment and those who had previously received treatment. And here, treatment is chemotherapy because this is the pre-immunotherapy era. What they found was that the response rate doubled from around 30% to the high 60s, and the median progression-free survival nearly doubled from around 6 months to around 10 to 11 months. Median overall survival with long-term follow-up was about a year and a half. We will look at the safety data in the next slide. And here, I think importantly is looking at the safety data for BRAF, small graphs, but looking at the safety data for BRAF monomer or BRAF monotherapy versus BRAF and MEK inhibitors. As expected, we do have an increase in certain toxicities, and these are mostly gastrointestinal toxicities with these combinations, so nausea, diarrhea, vomiting. I do want to call out pyrexia, which ends up occurring about 50 to 60% of patients in non-small cell lung cancer cohorts. And if we remember these numbers, because we'll look at them again in a comparison to another trial. Well, if we think about the discontinuation rate, it's about 12%, dose interruption rate about 2/3 of patients, and dose reduction rate in about 1/3 of patients. And so one of the key points that we learned from that Plantard study is that the activity of dabrafenib and trametinib was comparable if given pre-chemotherapy or pre-genotype agnostic therapy or after, which has raised a question in the field as we've had the incorporation of immunotherapy. Should we be reserving our BRAF targeted therapies for after immunotherapy? Unlike melanoma, we don't have any prospective studies comparing these head to head, but we do have retrospective, multi-center, global kind of studies that can guide us. And this is one such study. This is the Front BRAF study recently published that looked at patients who had received BRAF-MEK targeted therapy. So this is before the approval of encorafenib binimetinib, so largely dabrafenib trametinib, and compared outcomes for patients who received this in the first line versus those who received first line chemotherapy and immunotherapy. They found higher response rates with the targeted therapy, longer median progression-free survival, but actually truncated overall survival compared to if you received immunotherapy first. One key point in the non-small cell lung cancer space is that BRAF mutant non-small cell lung cancer is quite heterogeneous. About a quarter of patients have never smoking history, which tends to predict limited benefit from immunotherapy. And so when they dove into the data and looked for subsets that might benefit from upfront dabrafenib and trametinib, or who may not benefit as much from starting the chemoimmunotherapy, they found that having a never smoking status, having negative PD-L1 expression in your tumor, and perhaps having gray metastases were factors that might kind of shift the benefit a little bit. I think one important point in the context of BRAF mutant non-small cell lung cancer is that these prospective studies that led to dabrafenib and trametinib approval and encorafenib binimetinib approval didn't actually enroll many patients who had brain metastases. So as a field, we're still seeking answers and prospective answers and whether or not these therapies overcome brain metastases. But we do have reassurances from melanoma and case reports that they probably penetrate the CNS adequately. And so now we'll focus on the FARO study. This is a study that led to the approval of encorafenib and binimetinib for the first-line setting and a later-line setting. This is the study design. It enrolled patients who are treatment naive, who had BRAF V600 mutated metastatic non-small cell lung cancer, as well as those who are previously treated. Here, because it's a modern era study, patients had received immunotherapy. So the primary endpoint was the objective response rate, but they also looked at other key efficacy metrics and also exploratory endpoints that allude kind of the context of today's talk. And so in the treatment naive setting, the response rate was 75% at the initial readout. This is the waterfall plot here. I want you to focus on the patient in purple. Those are that small handful of patients who had primary progressive disease. So we can see the vast majority of patients had either disease stabilization or experience a partial response on treatment. At ESMO a couple months ago, we actually saw an updated readout that allowed us to see the median overall and progression-free survival with this encorafenib and binimetinib in the first-line setting. So the median progression-free survival is about 2.5 years, and the median overall survival is about 4 years, which it really is, in the absence of head-to-head data, substantially higher than what we saw with dabrafenib and trametinib. But one has to remember that the dabrafenib and trametinib studies were done prior to the incorporation of immunotherapy. What about patients who receive this after chemo and immunotherapy? There is differential benefit here, unlike what we saw with the dabrafenib and trametinib experience, where there's a 30% reduction in the overall response rate. So now you get to 46 to 49% for the overall or objective response rate in this patient population. If we look at the waterfall plot, there are more patients in purple. So there are some patients who experience primary progressive disease, but again, a kind of an impressive waterfall plot for these patients, and you can get partial responses in this context. Similarly, at ESMO, we saw an update of the data with respect to the median progression-free survival and median overall survival. As with the objective response rate, we do see a shorter median overall survival and a median progression-free survival when given after chemo and immunotherapy, here 9 months versus a median overall survival of just under 2 years. As a reminder, with dabrafenib and trametinib, the median overall survival is about 1.5 years or 18 months. So how does what do we think about in terms of the safety profile of encorafenib and binimetinib? So the safety profile is quite comparable to what we saw with dabrafenib and trametinib with respect to the incidence of gastrointestinal toxicities such as nausea, diarrhea, vomiting, etc. I think one thing to call out here is that the rates of pyrexia are substantially lower with this therapy. So 8% pyrexia, and pyrexia can be distressing for our patients. And so that is one reason, that and the differential efficacy, that this drug is, this combination is particularly compelling for patients with BRAF mutant non-small cell lung cancer. And so just to really reiterate that the key toxicities leading to dose interruption, so here 44% of patients had a dose interruption in the FARO study, really was driven by nausea and diarrhea, but we also have to monitor for transaminase elevation, so AST and ALT increases. Nausea and diarrhea also drove most of the dose reductions, which were experienced by 1 in 4 patients as far as the rates of dose reduction. And permanent treatment discontinuation rate is only occurred in 15% of patients. As a reminder, with dabrafenib and trametinib, that number was about 12%. And again, driven by nausea, diarrhea, and vomiting. One notable thing to point out here is that pyrexia or fevers were not driving these dose discontinuations, dose interruptions, or dose modification in general. So this is a table juxtaposing the efficacy data for dabrafenib and trametinib with that of encorafenib binimetinib. And this is a taboo to do because these are not head-to-head comparisons, but really just for us to better conceptualize and digest the data. And in two particular contexts, the treatment-naive setting and then those who had received prior treatment. And so in the treatment-naive setting, encorafenib and binimetinib has a 75% response rate, median overall survival of about 4 years, median progression-free survival of around 2.5 years. Dabrafenib trametinib is about 64%, 11 months, and 18 months, according to those metrics. If we look in previously treated patients, here dabrafenib and trametinib has a higher objective response rate, comparable median progression-free survival, and largely comparable median overall survival to encorafenib and binimetinib, which leads people to argue that if you're going to give encorafenib and binimetinib, it might behoove you to give it in the first-line setting, giving this drop-off in efficacy if given in the later-line setting. As far as the stacking up the toxicity profiles of both drugs, in the absence of head-to-head data, I think the most that we can say is that they both cause the characteristic toxicity is really gastrointestinal, but maybe the distinguishing factor is the pyrexia that is higher and more prevalent in dabrafenib and trametinib compared to encorafenib and binimetinib. The treatment discontinuation rates, dose interruption, and dose reduction rates, I don't think we can make much of those except to say a minority of patients will require dose reduction and an even smaller minority will require treatment discontinuation. And so now let's pivot to a patient's case. And I think this is gives us an incredible opportunity to think about how we might think about management of safety events with this therapy. And so this is a patient of mine, so a 72-year-old female with a 20-pack-year smoking history, has baseline obstructive sleep apnea and rheumatoid arthritis. Her rheumatoid arthritis is disabling enough to require immunosuppression, which is important when we think about immunotherapy for these patients. And so she initially presented with localized disease with a 1 centimeter right upper lobe nodule, confirmed on PET, and hilar lymphadenopathy. So clinically a stage 2 disease. They didn't have brain metastases. She had a biopsy that confirmed lung adenocarcinoma. We didn't do, this was before we did molecular testing in the context of early stage disease. So she actually went straight to the operating room and had a surgery, at which time she was found the surgery confirmed the stage 2 cancer, but also showed incidental stage 3A. That is, she had a involvement of a single and 2 nodal station. And so based on this, the standard of care is to consider radiation if they have multiple lymph nodes involved. She did multiple stage 3 lymph nodes involved, which she did not have, and then to consider adjuvant chemotherapy plus or minus adjuvant immunotherapy. We did not pursue immunotherapy because of her rheumatoid arthritis, and NGS showed a BRAF V600E mutation, which had no therapeutic implications for early stage disease and continues to not have one in non-small cell lung cancer. So she received 4 cycles of adjuvant chemotherapy, and approximately 14 months after completing chemo, she actually developed evidence of recurrent disease, and not just recurrent disease, but metastatic disease with gastrohepatic nodal involvement. And so based on these findings, these are her scans, really looking at the intrathoracic nodal recurrence. But as mentioned, she also had extrathoracic nodal recurrence. And after discussion with her, the options included rechallenge with chemotherapy, immunotherapy, which we wouldn't, which would probably be associated with more toxicity for her, versus a targeted therapy, we collectively elected to proceed with BRAF targeted therapy, and namely encorafenib and binimetinib at full dosing. And about 3 days after she started therapy, she called me, or her daughter called me and said, "My mom's not feeling well. She's having nausea, vomiting, diarrhea, and chills." She was not having frank fevers, but they asked us what to do. And so in this setting, she held the medications for a few days and resumed their and got a kind of enhanced supportive care, antipyretics, and was able to resume treatment. And so I think this gives us an incredible opportunity, as I said, and I'm going to bring Dr. Morris back in here too, for us to discuss what the potential toxicities of BRAF MET combinations and how do we approach the monitoring, patient counseling, and prevention.
Yeah, I mean, I think when we're thinking about BRAF, EGFR, it's a little bit different in colorectal cancer, right? Because we're using BRAF, EGFR. So some of the MEC-specific combinations may be a little less prevalent for us in colorectal cancer. But I think there's a lot of themes which overlap here. The pyrexia is something that we see often, in our patients. We try best just to kind of support them through that. I don't know that it really would cause dose reductions for us in that. And then we also just kind of counsel our patients just watching for arthralgias, especially in a patient with rheumatoid arthritis. Thinking about things like that. I just say kind of anecdotally, we really like Voltaren gel, like a topical NSAID, which has been helpful. And then I think the other thing, just we also kind of just counsel our patients with, which they may not be as used to if they're used to chemotherapy or things like that, or some of the unique skin symptoms that you kind of reference as well, like the pre-squamous cell carcinomas, the squamous cell carcinomas, the skin. So just a low threshold to get them plugged in to see a dermatologist if they start having new skin lesions kind of pop up.
Yeah, I think that's very helpful. In our case, when we started using these therapies, just because the proportion of our patients who have BRAF mutations is smaller than our melanoma colleagues, we leaned heavily on our melanoma colleagues to try to get kind of the tools of the trade and tips in terms of managing it. And so we were able to get this particular patient back on therapy and for her to do well on the therapy now for well over a year. And I think what we've learned in the space for non-small cell lung cancer and targeted therapies is that it actually, I keep using the word incredible opportunity because it is for patient engagement and just really promoting informed shared decision making with these therapies, making people aware of what to expect and empowering them to call us if they have these side effects. Then I just want to know in your clinic and in your how do you approach? Are you when you start patients on this therapy? Are you the one who's giving the advice on the therapeutic management? Do you call on other staff on your team to talk about side effects management and things that they might expect on therapy?
Yeah, I mean, we're fortunate to have fantastic pharmacists who work with us in the clinic, and we really as well go to our nurses and our physician assistants, nurse practitioners, and empower them with knowledge as well. So we really want to create a team, and I think that our nurses are APPs are very adept at recognizing and counseling on the side effects, the unique side effects of BRAF inhibitors as well. So it really does take a village, to help in the care of these patients. And it's really important to empower all members of my team with this information.
No, I agree. And I think one key thing to point out with these BRAF, particularly encorafenib and binimetinib, that our team makes sure to tell our patients, and one thing you have to keep an eye on when you start patients on these therapies is that there is quite a pill burden with this. And so making sure patients are there, they know how to keep track of the medications, et cetera. And I think one point that came up in this is the brain metastasis question. In non-small cell lung cancer, we feel comfortable giving it to patients with brain metastasis in the absence of prospective data, but it certainly is a population of patients that I monitor quite closely. Brain mets perhaps not as prevalent in colorectal cancer, but how does that influence your decision to use these therapies?
So you're absolutely correct, but they are more prevalent in BRAF V600E mutated tumors. So I believe there's a little bit better, at least for us, blood-brain barrier penetration with encorafenib. So we also feel comfortable, incorporating that systemically in our patients who have the concomitant brain metastases.
So we can all learn from each other. So just to summarize the metastatic lung cancer section, So there are multiple options that one can give for a patient with BRAF V600E mutant non-small cell lung cancer that's metastatic, including targeted therapies. We discussed 2 combinations today. I tend to prioritize the encorafenib and binimetinib combination just based on the efficacy data, and particularly the first-line efficacy data. But we, as a field, we're still sorting out whether or not to give immunotherapy for these patients. They can benefit it. So the story is distinct from our EGFR and ALK experience. Dabrafenib and trametinib, you have to remember, it works the same if given first or after genotype agnostic therapies. And there are maybe subsets of patients that may benefit from upfront immunotherapy versus targeted therapy. But here we're leaning on retrospective cohorts for that information. And I think sequencing strategies, that's what I was alluding to with the prior comment. I think as a field in non-small cell lung cancer, we're awaiting prospective data and not aware of any forthcoming studies. And so I think we're going to be leaning on large retrospective cohorts for this. And then brain metastases, again, I think that we have to lean on other disease settings that have proven that this is a effective strategy. And so at least in my clinical practice, I don't shy away from this combination for patients based on brain metastases alone. But it is an area where we need more information. And so with that, I want to thank you all for attending this educational session on BRAF mutated colorectal cancer and metastatic non-small cell lung cancer. And thank you, Dr. Morris, for joining me in this very lively and thought-provoking discussion. I learned a lot from you in the colorectal cancer space, things that I can apply directly back to advanced non-small cell lung cancer.
Yeah, this has been a lot of fun and really just such a pleasure to talk with you as well.
For additional resources, please remember to download the slides and practice aids at PeerView.com. And I hope you all found this program informative and useful to your practice. Thanks for joining us again.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Pfizer. To access all materials for this activity, visit peerview.com/NYM860.